go through some MCQs, just like mixed bag basically on O&G. So like try to vary it and do a bit of obs and a bit of gynae. So hopefully it will be useful, and also feel free to ask any questions as we go along, and I'll either answer them as we go along or answer them at the end. So first question is up. So we've got a 30-year-old woman who comes to a clinic at 24 plus 5 gestation. She's got a BMI of 32, so slightly raised, with a family history of diabetes. As such, you decide to test her for fasting glucose, and you find it is 6.8. What is the most appropriate initial management? So I think a poll will pop up at some point, and yeah, you should be able to.
So we'll give that 20 seconds because we launched the polls a bit later. So 10 more seconds. Okay. Has it come up on your screen, Justina?
No, it hasn't.
Oh. So basically we've got 6.
I see it now, actually. Oh. Now. Okay, cool. So, so most people have gone for A, some have gone for B, a few have gone for C. Okay, so let's go through it. So let's start off with, so offering insulin. So we'll go in reverse order. So offering insulin. So insulin can be used to manage gestational diabetes. So essentially, first of all, we have to look at the thing. So this lady does have gestational diabetes. Her fasting glucose is 6.8. So she meets the criteria for diagnosis of gestational diabetes. Insulin does form part of the management, but it's not like it's not the first thing you go for. And when you think about it, you know, insulin is a widely used drug. It's a good drug, but at the same time, it's a subcutaneous injection every day. And compliance, if you sort of start people on that straight away, probably won't be that great. So that's why it's not your sort of first initial management. So metformin, so you do start them on metformin, and the vast majority of women with gestational diabetes will end up going on to metformin, but you want to give these women a chance, and so that's why you would go with a 2-week trial of diet and exercise. So all women with gestational diabetes are referred to a dietitian, and there's also special diabetes midwives as well. And, you know, the key thing is that you want these people to be active. And there's a common misconception that in pregnancy you can't exercise, which is completely wrong. You can exercise in pregnancy. You have to be a bit wary of how you exercise, but, you know, exercise is recommended during pregnancy. And then diet. So you want these people to really look at their diet. In pregnancy, you don't eat for 2 as well. That's another misconception. You probably only need a couple of 100 extra calories, and that's like in the last trimester. So it's really looking at the diet, changing it, so it's like low carb, cutting out processed stuff. We know that the vast majority of women still end up needing treatment, but even whilst on treatment, you still want these women to make these dietary adjustments because it does help. So offer no treatment, so that's wrong. So women with gestational diabetes are at increased risk of a variety of things, including sort of macrosomia, neonatal hypoglycemia, as well as sort of stillbirths and other sort of post-antenatal, perinatal complications. So you want these women to be treated. Glibenclamide the beclamide, that is sort of your last sort of one of what you use sort of lower down your list of options. So you would use it if, for example, they don't tolerate metformin. So remember, metformin can make people feel quite sick. It can cause like diarrhea, vomiting, and some people don't tolerate it. So it can be alternative if people don't tolerate metformin. And you can also use it as an adjunct if metformin and insulin aren't doing the trick. So someone's asked, so would this woman not be offered an OGTT due to risk factors? Yeah, so this is what she's having. So the fasting glucose test is the OGTT. And essentially what you're doing is that you identify risk factors, and these are the risk factors here. So women with a BMI greater than 30, previous large baby, so greater than 4.5, previous GDM, a family history of diabetes, type 1 or 2 with in a first degree relative, or an ethnic minority with a high prevalence. And so if they've had previous gestational diabetes, then you test them earlier. So you test them within like the first trimester, early second trimester. But for all the other risk factors, you test them at around 24 weeks-ish is when you want to test them. And so these women become fasted, so you expect them not to eat, and you test their blood glucose at fasting state. So anything greater than 5.6 would indicate gestational diabetes. And then you get them to drink, it's like a sugary drink. I think it contains about 75 grams of carb. And you check their BM 2 hours afterwards. And if it's greater than 7.8, then that would sort of give you your diagnosis of gestational diabetes. And that's your OGTT. So in the vignette, when it's sort of the fasting glucose, she would have had a fasting glucose plus a 2-hour plasma. So it's not just a one-off. And with these women, you want them to, so from a fasting point of view, so you want these women, these women will be given a special booklet, and they basically essentially have to monitor their BMs at home. So they're given a glucose, like a BM monitor, and you want them to measure it like around meal time. So you want them to measure it before a meal. So ideally, it means they're fasting state. And then you want to measure it 1 hour after a meal as well. Sometimes you can do it 2 hours, but typically it's 1 hour after a meal. And you want them to do this every day and throughout the duration of pregnancy, so until term. And these women are followed up very closely. So they're seen in a joint diabetes antenatal clinic, normally about every week to 2 weeks, depending on how good their control is. And essentially you want to keep a close eye on these women, just so you know whether or not their diabetes is well controlled. So if it's not well controlled on diet and exercise, then you would add in metformin. You'd normally start off with low dose metformin, so about 500 mg, just because of the side effects, and then you can slowly taper that up until about 2 grams. And if that's not working, or they're not tolerating the increased dose of metformin, then you can add in insulin. Yes, and so in terms of postnatally, these women, you measure their BMs once they've given birth. Most of them, hopefully you should be able to just stop it because their BMs are well under control. But these women are at increased risk of developing type 2 diabetes. So essentially you need to recheck their blood glucose about 6 weeks afterwards, so normally in their postnatal check, and just to make sure that they haven't developed type 2 diabetes. If it's negative, then you can sort of continue, you can check their HbA1c annually just to make sure they're not tipping into type 2 diabetes because of that increased risk. And if their fasting glucose is high, then you continue treatment. and you will do a HbA1c, and possibly these women probably have type 2 diabetes, and so we'll just manage it as type 2. So next one, so a 38-year-old woman presents to her GP with lower abdominal pain, which she describes as a band across the front of her lower abdomen. She complains of instrumental bleeding, has 4 children, has taken the oral contraceptive pill to prevent any further pregnancies. She's been treated with gonorrhea and chlamydia in the past, but otherwise well. Her CA125 comes back as high. What's the most likely diagnosis?
Okay, so 20 seconds, guys. And 10. 5 seconds. Okay.
Okay, so I've got a variety of answers. So I'm trying to answer some questions sent in the meantime. Okay, so let's go through the answers. So someone said ovarian torsion. So ovarian torsion, so it does present with lower abdominal pain, but it tends often to be quite severe, and normally it's to one side, but it tends to present as severe abdominal pain. Ovarian cancer, so I guess the CA125 is high, but remember the CA125, so if it's high, you do think about ovarian cancer, but you also have to think about other ovarian pathologies. So it's high in other things, not just ovarian cancer. She's a young woman, so she's at slightly lower risk, but young women can get ovarian cancer, sorry. But she's of lower risk, and the answer is, what's the most likely diagnosis? Endometriosis does present as abdominal pain. It typically presents as like chronic pelvic pain, but she's on the oral contraceptive pill, and that acts as a protective factor to endometriosis, so it makes it less likely. Cyst rupture is also possible. She typically, again, it's normally to one side, the pain varies, but tends to be more severe, and you wouldn't expect intermenstrual bleeding with a cyst rupture. So the correct answer is pelvic inflammatory disease, so PID. So the reason why it's PID is because, so she's got this abdominal pain, and PID often presents with pelvic or abdominal pain. It also can present with intermenstrual bleeding, and she's got risk factors. So she has had previous chlamydia and gonorrhea. Even though they were treated, they are both significant risk factors for PID. So PID is relatively common, and it's basically infection of the gynae organs, so the uterus, fallopian tubes, ovaries. It's often due to an infection that's ascended via the cervix, and chlamydia and gonorrhea are your most common causes for PID. You can get other things like organisms that cause bacterial vaginosis as well. So as I said, it tends to present with pelvic pain and tenderness. You can also notice vaginal discharge, a change in vaginal discharge. So remember, vaginal discharge is normal. It's when it's changed or it smells, that's when you worry. Also abnormal vaginal bleeding, so this can be intermenstrual bleeding, it can be postcoital bleeding, so any abnormal vaginal bleeding. So remember, when you see a woman with abnormal vaginal bleeding, also think about cervical cancer as a differential, just because that can also present as abnormal vaginal bleeding. Dyspareunia is also another differential, another sort of clinical feature. And also, if you come across a young woman with dyspareunia, also do think about cervical cancer, particularly if it's deep dyspareunia. So if it's superficial, maybe think about other vaginal infections such as candidiasis, VV. But if it's deep, think about PID as well as cervical cancer. So any woman with PID needs a sexually transmitted infection screen done, just to rule out any STIs. And in general, you treat it with broad spectrum antibiotics. It does vary from trust to trust, so follow trust guidelines, but essentially you want to treat it with, so normally a penicillin, or you can use sort of like a fluoxetine or ciprofloxacin as an alternative if they're penallergic. Then you want to give some sort of atypical and gram-negative cover, so with doxycycline and metronidazole as well. So that's PID. So next question. So a 66-year-old woman presents to a GP saying that she has a lump down below. It's been there for a few months and she's been too embarrassed to come to the GP. On examination, there's a mass in the right labia and inguinal lymphadenopathy with no tenderness on palpation. What is the most likely diagnosis?
Okay, so 20 seconds. Ten seconds. Last few seconds.
Okay, so you've got a variety of answers. Most people have gone for vulval cancer. Some have gone for sebaceous cysts, Bartholin cyst, and then a few have gone for hepatic ulcer and lichen planus. Okay, so let's go through the answers. So lichen planus. So lichen planus. So it doesn't normally present as a lump. It's more sort of like stranding type plaque, can be quite itchy as well, and so that's why it's not that. A hepatic ulcer, that's a good suggestion, but she's 66 years old, so it's hopefully less likely. Remember, you know, she's at a low, I guess it's increasing in older people above 60, but it's less likely in someone of her age. So Bartholin cyst, it does present as a vaginal lump. That's very true, and will often be on one side, but you don't typically get lymphadenopathy with a lump. Sebaceous cyst is also, and also Bartholin cyst tends to be quite tender as well on palpation. They're quite painful, as are sebaceous cysts. So most likely is a vulval cancer. She's of the right age group. It's been there for some time, and also she's got this inguinal lymphadenopathy, and there's no tenderness. So these lumps tend to be non-tender, and they tend to be there for some time. So with vulval cancer, so it's not the most common type of gynecological cancer, but you do see it. Most are caused by most are squamous cell carcinomas, but don't forget you can also get skin cancers around the vulval region. So you can still get things like melanomas, BCCs, although less common, it can still happen. So think about squamous cell carcinoma as your most likely cause, but you also don't forget that other skin cancers can present on the vulvar region. When you examine, typically it's a lump or ulceration. It's quite difficult to find pictures of vulval cancer, but this is what I managed to find. And you'd often see lymphadenopathy. If it's caught quite early, then you might not, but you can see inguinal lymphadenopathy. In terms of treatment, as with all cancers, it depends on how advanced it is. So if it's simple, and I'll go through the stage in a second, then radical or wide local excision is enough. You just need to make sure that there are good margins. If there's multifocal disease, then you will think about radical vulvectomy, and don't forget you can still do reconstructive surgery afterwards. If it's advanced, so if it's sort of spread to other gynecological organs or spread further afield, then radiotherapy, and sometimes you can use adjunctive chemotherapy as your options. So in terms of staging, so don't expect people to not know the FIGO staging of every single gynecological cancer just because, but it's a good idea, it's worth just knowing, just having a brief idea of the staging, just because it varies from cancer to cancer. So the staging of vulval cancer is different to the staging of cervical, which is different to the staging of endometrial. So I wouldn't expect you to know it in detail, but just like have a brief idea as how it's staged. So just touching on the other differential, so lichen planus. So lichen planus essentially is just a chronic inflammatory skin condition. You can get it anywhere, but you can also get it on the vulval regions. You typically see it in middle-aged women, so women between like their 40s to 60s-ish. And it's typically painless. It can be painful though, but you'll see white streaks, and it sort of looks very similar to this. Sometimes you can get scarring, which can lead to like adhesion formations, particularly between sort of the majora and minora. And it can present as, you can sort of have symptoms of vaginitis, bleeding, dyspareunia as well. And it's typically treated with steroids. So lichen sclerosis is also another sort of differential. This typically affects women who are greater than 50, and the reason why it's worth knowing about this is because there's a link. We know that some women with this can go on to develop vulval cancer. So we say about it's normally less than 5%, so it's a small proportion, but it's still a significant proportion. So men can get it as well, but it's more common in women, and it typically appears as sort of these white patches. Again, you can get scarring. It can be itchy, but sometimes people can be asymptomatic. And typically, because of this chronic inflammation, there can be irritation. So people might complain of dysuria, dyspareunia as well as sort of your symptoms. So this is often treated with steroids as well. Sometimes you can remove it, but there is a high risk of reoccurrence if you do remove the affected areas. If it's uncontrolled, then there is an increased risk of vulval cancer. So next question. So a 19-year-old woman, a woman is brought into hospital with her partner because she's experienced a now resolved episode of PV bleeding. She's 34 weeks pregnant and has had a C-section for pregnancy 2 years ago. The patient is adequately resuscitated and a transvaginal ultrasound is performed. A diagnosis of major placenta previa is made. Which of the following describes the best management in the patient's pregnancy?
So 20 seconds left. Ten seconds. 5.
So, okay, great. So there's a bit of a mix. So no one's gone for A, which is good because you don't want this lady going home. But there's sort of, it's quite mixed between B, C, and D, which is what most people have gone for. So induced labour. So I guess this woman's bleeding, so you might want to think about maybe getting sort of, you want that baby out. But she's 34 weeks pregnant. She's had an episode of bleeding. She's been resuscitated. The bleeding stopped. So when you want to sort of think about the risk and benefit, so you know the baby's still preterm, so you don't want to sort of jump to inducing labour. But also the big thing is that she's got placenta previa. So anyone with placenta previa, you don't want them to deliver vaginally. There are a few exceptions, but for the vast majority of women with placenta previa, so low-lying placenta, the risk particularly of bleeding is high, and particularly if the placenta covers the OSCE, which I'll go through in a second, vaginal delivery isn't possible. So inducing labour wouldn't be your option. As well as, so discharging the patient as well isn't appropriate, just because, you know, this woman, we know she's got a major placenta previa and she's had an episode of bleeding already. Even though she's stable, you want to keep an eye on this lady, essentially, just because, you know, the risk associated, the bleeding risk associated with placenta previa can be quite high. So then we've got sort of delivering immediately by C-section. So this isn't an unreasonable suggestion, but at the moment she's quite stable. So if she was unstable and the bleeding wasn't controlled, then by all means she will need an immediate C-section. But this lady, you know, she's had the episode of bleeding, but it's stopped. Don't forget she's premature, and also she's now stable. So when you look at sort of the risks/benefits, at the moment there's no real need for an immediate C-section. So plan a C-section and discharge the patient. So she already has a C-section planned. Or you would expect her to have a C-section planned, I guess, because she has placenta previa. If she doesn't, then I guess it's not unreasonable to think about planning a C-section. But you don't want this woman to just go home. So someone who's had PV bleeding, particularly in the last trimester, you don't want them to just go home. You want to keep an eye on them if they have placenta previa, just because of that risk of a recurrent bleed. So the most appropriate option would be to admit her. You want to admit her, keep an eye on her, look out for and monitor any episodes of PV bleeding. So you'd ideally get her to wear a pad and ask midwives to monitor the pad. At the moment she's stable, which is good, but you would want to think about, you know, when you would want that section to be. You want to make sure that she continues to be stable, make sure her HB is stable as well. And just, you know, essentially you just want to make sure that she doesn't have a further bleed. So someone's asked about, would you admit anyone who's found to have placenta previa? So you don't, so if someone has placenta previa, you don't admit them. They can go on about their lives. There are certain things they have to be cautious of, but if they have placenta previa and they have PV bleeding, then 100% you would admit them. And in terms of considering anti-D, so yes, so any woman who's bleeding, who's rhesus negative, you'd want to consider giving them anti-D just because of the risk of sensitization. Someone's asked about giving dexamethasone. So I guess, so she's 34 weeks. So if you are thinking about, so in this case, I probably would give dexamethasone, just because I'm worried that she will probably, the chances are, or there's a risk that she will probably bleed again. So I would start thinking about giving this woman dex. Once she's had dexamethasone, if she had it at 34 weeks and she had no problems with bleeding until her C-section, that will say at 39 weeks, then that's great. You don't need to give dexamethasone again. You normally only really need to give a one-off course of dex, so normally 12 or 24 hours apart. But yes, definitely, she's coming with bleeding. There's a risk that you'll have to do a preterm C-section. So yes, dexamethasone would be useful for the neonatal lung protection. In terms of how long would you admit some placenta previa, I think it depends on how they are. So if the bleeding stopped and they're stable and there's no further concerns, and you can safety net them appropriately, so in terms of you want them to come back if any further bleeding, the placenta looks okay on scan and it was just a one-off, then potentially she could go home, but with close follow-up by midwives and also in antenatal clinic. And in terms of, and yes, so, and in terms of it with the vignettes, yes, so she didn't have a planned C-section, but anyone with placenta previa, you should plan a C-section. So most women have a 12-week and a 20-week scan. In that 20-week scan, if the placenta is low lying, then you would rescan them again just to make sure that it's coming up. If it hasn't migrated upwards, particularly in the last trimester, then you would start thinking about the fact that they have placenta previa, because the chances of it migrating upwards now decreases, and then you would monitor. And if she continues to bleed and she's not stable, then you just start planning a cesarean section. And it depends on how much she's bleeding. So if she's hemodynamically unstable, then you want to do sort of like a category 1 cesarean section, so the baby's out within half an hour. But if she's just trickling but she's stable, you can monitor, but you'd want to give an early C-section. In terms of the dex, so the dexamethasone isn't for the placenta previa, it's to treat, so whenever you have a preterm baby, their lungs haven't matured from a surfactant point of view. So you're giving them the dexamethasone for the baby, not for her. So it's not to treat the placenta previa, it's to treat it's to help with surfactant production in your preterm baby. So someone's asked, so if they were 15 weeks gestation and had PV bleeding with placenta previa, would you admit? So no, because at 15 weeks you won't diagnose placenta previa. So even at 20 weeks you won't diagnose it. The placenta will migrate upwards, and it should migrate upwards as gestation sort of continues. Certainly in sort of after 28 weeks, if the placenta is still low and it's near the OSCE, then you would diagnose placenta previa. But PV bleeding in a woman at 15 weeks of gestation, I'd be worried about a miscarriage rather than placenta previa. And you also want to make sure that it's not an ectopic, make sure that she's got an intrauterine pregnancy. In terms of anti-D, so anti-D is what you'd normally give to rhesus negative women, and that's just because of the risk of sensitization. You would give it, so in certain circumstances, so if they are less than 12 weeks, which is the question that's been asked, you'd give it if they had a termination of pregnancy or a surgical management of miscarriage. You wouldn't necessarily give it if they've had bleeding, just because we know that the risk is slightly lower. But in any woman who's particularly in the last trimester, any significant bleeding, you would give anti-D. And of course, after labour, you would have to give it as well. So, and it's also routinely given at around 28 weeks to all women who are rhesus negative. Great. So with placenta previa, so it typically presents as bright red vaginal bleeding, which is painless. You should suspect it in any woman in the final trimester, so essentially after 24 weeks, if there's vaginal bleeding. If someone comes in with vaginal bleeding, particularly in their final trimester, you want to scan them to exclude a low-lying placenta, because that's sort of the thing that you're worried about. Of course, so vaginal bleeding, you will see quite often, and it can be caused by a variety of things. Other differentials include an abruption, but that tends to be painful. Sometimes it can be trauma related, so if they've had sex and they've had some spotting as a result, that can also cause some vaginal bleeding, but it's to a lesser extent. So in terms of investigation, so if anyone has bleeding after the first trimester, you want to scan them. And in the sort of first trimester and early second trimester, most likely it's a miscarriage, but you also want to think about where their placenta is. And as I said, after 20, the placenta tends to migrate upwards, and even up to 24 weeks, it can still migrate upwards. Women who've had a previous history of uterine incision, and this can be of any kind, so a previous cesarean section, a previous sort of myomectomy that's resulted in a uterine incision, any type of incision to the uterus, you should do a scan as well, just to rule out placenta previa. These women, if they have low-lying placentas, they will need serial scans just to keep an eye on where that placenta is. And I'll go through different types of placenta previa in a second, but you need to just keep a close eye on where that placenta is, because occasionally it can migrate upwards even later on, but normally once you get to the final trimester, it's less likely. So in terms of managing placenta previa, so in any woman who's pregnant and bleeding, you want to do ABCD. You want to make sure that they are stable, correct, so blood pressure with fluids, group and save, make sure you've got blood ready, and you want them to be stable. If you don't know where their placenta is, then you will do an urgent ultrasound. And occasionally you do get women who, for example, most commonly, most women will have their last scan at 20 weeks. And so if you won't know where their placenta is apart from that 20-week scan, so it's definitely worth rescanning them. If you have a woman who's just never engaged in antenatal care, or they've booked late, then again, you'd want to do an urgent ultrasound scan. If at any point in any woman who has PV bleeding and you cannot control it and she's unstable, you just go for an immediate C-section. If they have known placenta previa, then you want to stabilize them. And the key thing is, if they're not stable, as always, you just go for an emergency C-section. As suggested before, you'd also give dexamethasone, and that is just your steroid cover for your preterm baby. If you have someone with known placenta previa and they come in labour, you just go for a cesarean section. So these women should not, if they have placenta previa, ideally they should not be allowed to labour vaginally, just because of that risk of bleeding. So if they come in and they're contracting, you just plan a cesarean section. So if you have so in other circumstances, so if you have a woman with PV bleeding, with placenta previa, but without bleeding, in general, you just monitor them, as I said. You advise rest, particularly pelvic rest, and that means essentially you want them to avoid penetrative sexual intercourse. And with known placenta previa, and in general with pregnant women, any PV bleeding should be they should come in for a review. So with regards to placenta previa, so there are different grades, or it can be called different things. So you've got grade 1, which is essentially where the placental edge is near, it's near the low, is in the lower uterine segment, but it doesn't cover the os. So this is an example of grade 1. So it's near the os, but it doesn't cover it, but it's low lying. So ideally you'd want your placenta to be up here or anterior posterior, but not near the os. Grade 2, so if it reaches the os but it doesn't cover it, so that would be called grade 2, or also called a marginal placenta previa. So as you can see here, it's low lying again, but it's close to the os, but it's not covering it. Grade 3, so it covers the os, but it doesn't, but it's partial, so it doesn't completely cover the os essentially. So this is your example, and this is also called partial previa. And then you have grade 4, which is where essentially it completely covers the os. And particularly in these cases, you know, vaginal delivery is absolutely contraindicated, including in marginal previa. But obviously, you know, if the placenta is covering the os, then labour essentially is very, very dangerous. It's probably not possible, you know, and so these women, absolutely, you don't want them to labour vaginally. So the general consensus is that if you have someone with known placenta previa and they come in and they're labouring, you just plan a cesarean section. So you bring their section date forward. So just other differentials. So we touched on other differentials of PV bleeding. So placental abruption is another thing that's worth knowing about. And essentially, this is when it essentially separates from the uterine wall during pregnancy, and this results in hemorrhage. So the placenta in reality should only separate after the baby's delivered, so i.e. in your stages of pregnancy, your stages of labour, sorry. But if it separates prematurely, this can result in bleeding. Don't forget the placenta is a massive has a lot of vascular supply, and so that's why. Typically it presents with PV bleeding, but it tends to be painful. It can, when you feel them, you have this sort of stereotypical hard woody uterus, and sometimes they might present with contractions as well. They might note reduced fetal movements, because don't forget that baby has, you know, the placenta is the supply for the baby, and if it's separated to any degree, then obviously the fetus is affected. And these women can come in hypovolemic shock. Don't forget, with placental abruption, sometimes it can present as just abdominal pain without PV bleeding. So sometimes the bleeding can be concealed. So whenever you think of a woman with abdominal pain, don't forget abruption is also one of your big differentials, even though there isn't PV bleeding. Risk factors for abruption include like trauma, hypertension or preeclampsia, multiparity, so women who have had lots and have had quite a few babies, as well as increased maternal age. Other things include polyhydramnios, so just lots of increased fluids, amniotic fluids. If you've had a previous history of abruption, then you're more likely to have it. Coagulation disorders and substance misuse. So I'll just go through some other placental abnormalities, which can also present with bleeding as well. So ideally, a normal placenta sort of adheres sort of where the endometrium is, but occasionally it can sort of abnormally adhere. So there are different types of sort of abnormal adherences. Accreta is the most common, and essentially it adheres directly onto the myometrium, so that muscle layer, but it doesn't invade it. Increta is when it invades through the myometrium, but not it invades through, but not completely through the full thickness. whereas Precreta is where it sort of goes through the full thickness of the myometrium and through the serosa. And with Precreta, there's also a risk that the placenta can also invade into sort of nearby abdominal organs as well. So risk factors of placenta previa or sort of adherence abnormalities include previous terminations, dilated D and C. C-section also increases that risk, and it's with cesarean sections, the placenta tends to abnormally adhere into that previous scar. Advanced maternal age, placenta previa, as well as any type of uterine structural defects. So in terms of investigations, so you do ultrasound as normal, but also you may also want to do an MRI just because you get better detail. If any abnormal implantation is suspected, these women you want to offer a cesarean section just because it's the safest option. Ideally, with these women, particularly with Precreta, you want them to have a hysterectomy, just because once they've had an abnormal implantation once, there's a risk of further abnormal implantations in future pregnancies. Of course, there are times when women want to preserve their fertility, and sometimes, and this is normally done at specialist centres, you can look at sort of ways of resecting while sort of preserving the uterus. So next question. So a 25-year-old woman presents to the GP complaining of a 2-day history of thin, grey, offensive discharge. On speculum examination, there's no bleeding, the os is closed, vaginal swabs are taken and demonstrates Gardnerella vaginalis. And a pH test gives an abnormal alkaline result. So she's worried about this, as she's currently 30 weeks pregnant with her first baby. Given the most likely diagnosis, which of the following is a potential complication?
Okay, so 20 seconds left. Ten seconds. 5.
Okay, great. So first of all, with this question, we want to know what this woman has. So we've got a variety of answers. Most have gone for E, and some have gone for B and D as well, and a few have gone for C and A. So first we want to know what the diagnosis is that this woman has. So she has BV. The reason why she has BV is because she has presence of Gardnerella vaginalis, and also you get an abnormal alkaline result. Don't forget the pH of the vagina is normally low. She's also got this thin, grey, offensive discharge, which is quite typical of bacterial vaginosis. So with bacterial vaginosis, there's an increased risk of preterm delivery. There's not an increased risk of maternal sepsis, just because her membranes are intact, so that decreases the risk, but also the fact that we know that it doesn't increase the risk. There's no association with macrosomia and BV. Neonatal conjunctivitis you tend to get if the mother has gonorrhea, I think also chlamydia as well, but that's when you can get neonatal conjunctivitis. And increase of prolonged pregnancy, there's no increased risk. So vaginal discharge is so all women are expected to have some degree of vaginal discharge. The key thing is the change in vaginal discharge. So BVs, or bacterial vaginosis, so essentially it's basically an overgrowth, a bacterial overgrowth, leading to a change in discharge associated with a fishy odour. It's associated with a variety of bacteria, but most commonly Gardnerella is like your most common sort of organism that it's associated with. There are different diagnostic criteria. So there's the Amstel criteria and the Eisen/Hay criteria. I come across the Hay criteria more often at work, and normally when I send swabs, I will normally get a grade 1, 2, or 3. Grade 1 is normal and lactobacilli is predominant, and that's what you would expect in a woman without BV. Grade 2 is indeterminate, so there's some lactobacilli, but there are other organisms present. If you get a woman with grade 2, who's grade 2, then it depends on how she is. So if she's very symptomatic and you think that this is Barn-Dole BV, then you can just go ahead and treat. But you can also just repeat the swabs and see what the repeat swab shows, and hopefully it will guide you and be either grade 1 or grade 3. If you get grade 2 again and she's still symptomatic, then you just treat. If it's grade 3, so they have BV, then you just treat. And treatment is usually with metronidazole or clindamycin. If they're pregnant, metronidazole is your drug of choice, and usually it's just a one-off dose. The Amstel criteria is also what is also used. I haven't seen it used in practice, but it is also a criteria that's used. And essentially, you want a raised vaginal pH, so greater than 4.5, grey discharge. There's a whiff test, which basically is when you add potassium hydroxide and you get a fishy odour, and then you'll see clue cells on a wet mount. So other causes of vaginal discharge. So trichomoniasis is also a cause of vaginal discharge, and this is essentially a protozoal infection. It's sexually transmitted with an incubation period of around 7 days. Women can be asymptomatic, but also classically they have this sort of profuse, thick, frothy, yellow vaginal discharge. They can also present with vaginal irritation and dyspareunia. You do see it in men as well, and it can cause you arthritis as well, but it can also be asymptomatic. If you do a speculum exam, you can see a strawberry cervix, but it's not common, and you don't often see it. But in like a vignette question, so like in an MCQ question, often you'll see strawberry cervix seen on speculum exam. And if you see strawberry cervix, it's going to be trichomoniasis. In terms of diagnosis, so you take swabs and you microscopy and culture it, and again you treat with metronidazole. Because obviously it's a sexually transmitted infection, if you've got one sexually transmitted infection, there's a risk of having other sexually transmitted infections, so you'd also offer an STI screen as well. So the most common cause of vaginal discharge, and you'll see this a lot. Actually, you probably won't actually see it a lot, actually, because most women will just treat it themselves. But candidiasis is your most common cause of vaginal discharge. You'll see it a lot in pregnant women, and in women in general, it's very common. Risk factors include sort of pregnancy, as said, and antibiotic use is also a risk factor, as well as immunosuppression of any kind. I remember someone did say I remember a GP saying to me that if you see a woman with repeated candidiasis, you also think about maybe they have like underlying diabetes, just because they're immunosuppressed, and that can be the reason why. And the method of transmission is generally non-sexual. So now with candidiasis, it's typically itchy, and you get this sort of thick white, you can see here this thick white curly discharge. It sort of looks like gone off milk, is what I'd probably best describe it as. Women we can complain of pain whilst passing urine, as well as dyspareunia. Because it's so itchy, it can be quite red when you examine the genitalia, and there might be some swelling as well. And if you do a speculum exam, often you'll actually see quite a lot of discharge around the speculum and around the sort of the walls of the vagina. Men also get candidiasis, don't forget, and it presents with soreness, pruritus, and redness as well. So, and just to confirm, so yeah, the correct answer, just going back, was increased risk of preterm delivery. So any woman with BV, any woman with BV in general, you want to treat because they're symptomatic, but particularly in pregnancy, you want to treat it. And so I've just sort of compared the discharges and vaginal discharges in women. So BV, and this is more for like a diagnostic point of view and also from a like MCQ point of view. So with BV, you would expect it to be grey and it typically has a fishy smell. Whereas with candidiasis, you expect it to be thick and white, and it normally doesn't have a smell. So occasionally you can get like a slight smell, but it's normally odorless. And then trichomoniasis is yellow/green, and it has a foul smell. I don't know what it smells like, but it smells foul. All of them will present with itching. Back to BV can be asymptomatic, but all present with itching and soreness. And with trichomoniasis, don't forget that strawberry cervix appearance. Although it's uncommon and you don't in practice see it that often, and for some reason, like vignettes, they like to put it in just because I guess it points towards trichomoniasis as your answer. So skip over that one. So because of time, I'll just skip over a few. So this one, so 27-year-old woman who is 8 weeks pregnant presents to a GP with left iliac fossa pain. She's referred to the hospital and undergoes a transvaginal ultrasound, which reveals a 40mm mass in the fallopian tube with fetal heartbeat present. She is type O rhesus negative. What is the most appropriate management?
Okay, so it's 10 more seconds. Sorry for not giving a warning. 5 more seconds. Okay.
Okay, so I think I've lost the poll. Okay, great. So most people have gone for C. Let me just go back so that you guys can see what C is. So salvingectomy and anti-D. Some have gone for A, methotrexate. Some have gone for a single dose of methotrexate. Some have gone for expected management, and a few have gone for self-injectomy on its own. So let's go through the answers. So single dose of methotrexate and anti-D. So it's not unreasonable, but you know, methotrexate is what you would use to treat an ectopic pregnancy, particularly a tubal ectopic pregnancy. But don't forget, this woman's in pain, and also she's got a heartbeat present. So the fact that she's in pain and there's also a fetal heartbeat means that you don't want to use methotrexate, and this would be an indication for a surgical management, so for a self-injectomy. With B, even if you were to give methotrexate, you still need to give anti-D because she's rhesus negative. Expectant management, ideally you wouldn't do, just because, you know, she's in pain. There's a fetal heartbeat present, and so there's a risk of rupture. And these women, they do come in, and from experience, they have come in shock, so hemodynamically unstable from ruptured ectopics. So you don't want this woman going home without treatment. And self-injectomy is the correct answer, but because you're doing a self-injectomy, you need to cover her with anti-D because she's resource negative. So an ectopic pregnancy essentially is any pregnancy that implants outside of the uterus. And risk factors include, so PID is a risk factor just because you can get scarring, which can affect how your fertilized product sort of moves through the tube into the uterus. Any pelvic surgery as well, because again, you get scarring or adhesions. If they have a coil, so any type of coil, so Mirena or copper coil, will increase the risk, even though, so it's a relative risk. So they're less likely to get pregnant in general because they have a coil in, but if they do get pregnant, they are more likely to have an ectopic pregnancy, if that makes sense. And then IVF is also an increased risk. So any woman who presents with abdominal pain, any woman of childbearing age who presents with abdominal pain, you need to get a pregnancy test. So there's no reason why you should ever have a woman with abdominal pain and they haven't had a pregnancy test. That's one of the first things you do. It doesn't matter if she's on any form of contraception, so she could be on the pill, could have an implant, it doesn't matter, you still do a pregnancy test. Any woman with abdominal pain who is pregnant, so they're HCG positive, it's an ectopic until proven otherwise. So of course, pregnant and abdominal pain can be, a differential can also be miscarried, but the first thing that you want to rule out is an ectopic. And that's just because these women, there's that risk of rupture. I've seen women lose 2-3 liters from ruptured ectopics. So it's not something that you want to miss. So typically it presents with pelvic or abdominal pain, but it can also present with shoulder tip pain. And I remember speaking to a consultant who said that actually they came across someone who, a woman of childbearing age, who essentially she came in with shoulder pain. And when you think shoulder pain, you think it's probably just MSK, but she was sent home, came back more unwell, unstable, and it turned out that she had an ectopic pregnancy. So shoulder tip pain, don't forget, is caused by irritation of the diaphragm, and so if you have an ectopic, that can cause shoulder tip pain as well if you have bleeding that sort of irritates the diaphragm. Of course, women with ectopics can present with vaginal bleeding, but it's not always the case. And so you can have women who have an ectopic and there's no vaginal bleeding. And don't forget, this is an early pregnancy. So if you have a woman who's come in and they have abdominal pain and they've missed their period, then you want to think of an ectopic pregnancy. And with ectopic pregnancies, you want these women to be stable. And that's your first, that's the first thing you want to do. From a management point of view, so this is your this is sort of how you'd want to manage it. So if it's conservative management, if they have a low HCG, so less than 1/500, and it's decreasing and there's minimal or no symptoms, then you can just watch them with serial HCGs. If it's not falling, then you'd go for medical management. Medical management will be methotrexate, and you follow them up. If it hasn't worked, then you give them a second dose, or you offer them surgical management. Surgical management will be with a self-injectomy, and that's your first line, that's the first thing that you want to do, and that's removal of the tube and the ectopic. And indications for this would be a high beta HCG, and a dextral mass greater than 35 millimeters, significant pain, or if a fetal heartbeat's present. Sometimes you can offer a self-injotomy, which is essentially where you just take out the ectopic through an incision of the fallopian tube. And you'd offer this to women who have any reason for reduced fertility already. So if they've had PID or they've had a previous self-injectomy, then you'd want to offer them that, but you'd have to just let them know that there is a risk that tissue is still left behind and you need to follow them up. So we'll just finish off quickly on CTGs because someone wanted, someone asked about CTGs before. So it's a 35-year-old woman who presents to the labour ward who's 35 plus 5 with a 2-hour history of bright red bleeding. She so this was sustained on her underwear. So before the onset, she noticed a gush of blood and fluid. She's previously been well and has had intermittent abdominal pain. The blood pressure is okay, her pulse is 90 and she's apyrexial. Fetal movements have been normal and her CTG is reassuring. The OSCE is 2 centimeters dilated with moderate amounts of bleeding, and there's a grade 3 placenta previa as noted on her ultrasound scans. So what is the most appropriate management for this patient?
Okay, so 10 seconds left. Five seconds. 3, 2, 1.
Okay, so most people have gone for A, so urgently take her to theatre for a caesarean section. No one's gone for B. Some have gone for C, so reassess the placental position. D, give tocolytic agents, and E, admit to labour ward. A few people have, but 1 or 2 have gone for. So this woman's bleeding. And it sounds like she bled quite a lot at the start, as well as a gush of fluid. So you do worry wonder whether she has gone into labour because she has intermittent abdominal pain as well as blood and fluids. So, you know, this might have been a rupture of membranes as well as, you know, some bleeding associated with her previa. But the fact that she's having intermittent abdominal pain makes me think of the fact that she's now in labour. So even though this woman is relatively stable, we know that she's got a grade 3 placenta previa. So don't forget, so that's where it sort of partially covers, where it covers the os, but not fully. So it covers the os fully, but the placenta isn't central, sorry. But also the fact that she's in labour. So you don't want this woman to go into labour and you don't want the baby to try and descend, because obviously we know that the placenta is covering the os. So this woman needs an urgent C-section. We don't want to wait. You know, even though she's stable, we don't want to wait. So induction of labour. So, you know, she has a grade 3 placenta previa, so you don't want to induce labour in this lady. You just want, she should just have a caesarean section. So I guess, you know, with C, which is what the second most picked answer, I guess, you know, reassessing the placenta isn't unreasonable, but this woman's in labour. So, and, you know, and with labour and contractions, the baby descends. And if you have a placenta that's covering the os, you know, where is the baby going to descend to? So we don't want this, we don't want to sort of, we don't want to hold off. You know, she's in labour, she's had bleeding as well. Even though she's stable, she needs an emergency caesarean section. Tocolytic agents and corticosteroids. So she is 35 weeks. So I guess with caesarean sections, if you're doing a C-section, and it varies from trust to trust, but normally if it's less than 39 weeks, you would offer steroids if it's a caesarean section, and that's just because then babies aren't getting that sort of the stimulation from being vaginally delivered. But, you know, she's of an okay gestation. She's nearly 36 weeks. There's probably not enough time to give steroids. You could give steroids, but it probably won't have much of an effect. But and you wouldn't want to, you know, she's bleeding, she's at a good enough gestation, so a tocolytic agent, which is basically an agent which stops contractions, wouldn't be appropriate. And with E, as said already, you don't want this woman to give birth vaginally. You know, her placenta is covering her os, so the risk of hemorrhage it outweighs a vaginal delivery, so it's just too high risk. So with the CTG, so CTG is essentially, and for those who've had placement on labour wards, you'll see it all the time. It's essentially a way of assessing the fetus or assessing the baby, and it also looks at uterine contractions. So this is the example of a CTG, and so the top part of the CTG will basically show the fetal heart rate trace, and then the bottom one is the contractions. So, and each sort of, so when you see these numbers from here to here, that represents 10 minutes. When you look at the number of contractions, so this will tell you that there's uterine activity, so it'll show you that, okay, she's contracting, but it doesn't, but the peak isn't proportional to how strong the contraction is. So if you have a peak, you could have this peak, which is quite small or relatively small, and she might have like very strong contractions. So there's no sort of relation between the two, but it tells you that there is uterine activity. And then you look at that, and then you've got the fetal heart rate trace. So with a so midwives are very good at looking at this, and as a medical student, I would expect you just to have an idea of what a CTG is and what a normalish CTG looks like, but like the details of it is not expected at medical school, but I guess it's nice to know. The key things is that you need to know that a normal heart rate is between about 110 and 160, and essentially you just want there to be like a nice sort of like pattern like this. This looks like a good CTG. This basically goes into detail a bit more about a CTG, which I wouldn't expect a medical student to know about in detail. But when I said like your squiggly line, so that's basically your variability. And your variability, you want it to be between 5 and 25. So you want to work out where your baseline is, and this baseline is probably around, I would say, 120 to 130. And you want to look at how much it varies around your baseline. So you want it to be between 5 and 25. A good CTG doesn't have many decelerations or repetitive decelerations, and you want there to be some accelerations as well. So these are examples. So this is what deceleration looks like, and can you see it's repetitive, and that's what you don't want. This shows accelerations, so to these nice peaks, and this is what you would expect to see in a good CTG. And then this is like a sort of, this is a CTG that looks like a basically more or less a straight line, not quite, but nearly there. And you don't want to see this just because, and sometimes you do see it with particularly the baby sleeping, but you don't want to see it for a prolonged period of time. And so this is what you would call a CTG with reduced variability. So you're not getting that up and down appearance. Perfect. So that sums up today's session. There's quite a few questions which I'll